turn it back over to Paula.
Thank you so much, Amanda. I now have the great pleasure of introducing our first speaker, Michelle Danica, medical doctor. Michelle has been a board-certified geriatrician for almost 25 years. She trained at the University of Massachusetts Medical School and the Highland General Hospital in Oakland. Prior to joining Elder Consult, Michelle developed the house call program for New Zealand. Dr. Danica has extensive experience caring for people with dementia. She believes in a holistic approach and the importance of partnering with patients and their families in promoting dignity, respect, autonomy, and self-efficacy for older individuals. She has a particular interest in utilizing physical activity to maintain physical and cognitive health. Dr. Danica is a fellow in the American and the Royal Australian Colleges of Physicians. In her presentation today, Dr. Danica will highlight some of the primary ways medicine can be used to treat Parkinson's symptoms.
All right, can I get started?
Absolutely.
Okay, so thanks for that lovely introduction, Paula. So before I talk about medications, I just want to talk a little bit about Parkinson's disease and Lewy body dementia, because there's a tremendous overlap and oftentimes that can be confusing. So Paula gave you a really nice discussion about Parkinson's disease with dementia. Just mentioned sort of some of the things that I want to highlight, which are that there's tremendous crossover between Lewy body dementia and Parkinson's disease. And one of the things that's difficult is to distinguish which is which, and people would always like to know what they are. So the way I conceptualize it is people have Parkinson's disease, and then, so those are those motor symptoms. That's the bradykinesia, slow movements, tremor, and it can be some postural instability where people can't hold themselves upright, and rigidity. So they're stiff. Those are the motor symptoms. And then they'll develop the cognitive changes later. In Lewy body dementia, the dementia starts first, and then the Parkinson's begins. But when we look at them clinically, it can be very difficult to tell, because people say if the person has hallucinations, they have Lewy body dementia, but actually people with Parkinson's disease and Alzheimer's disease frequently develop hallucinations. So when you look at the microscope, there is some difference in the neuropathology between Lewy body dementia and Parkinson's disease. And that really has to do with how the kinds of proteins that are deposited in the brain. And so with Lewy body, those infiltrates are called alpha-synaptin proteins. And in Parkinson's disease, the similar things happen, but you get these Lewy body clusters, but they occur after the age of 65, whereas in Lewy body, they occur immediately, and it's a much more rapid damage to the brain. So as Paula said, that when you have Parkinson's disease, as the disease progresses, people develop dementia. And so we know that with the initial diagnosis of Parkinson's disease, as many as 10 to 35% of people already have some cognitive impairment. But as that disease progresses, so by the time you hit 15 to 20 years, it's 60 to 80% of people have dementia. That dementia is going to be more profound and occur more quickly if the diagnosis of Parkinson's disease is made after the age of 70. So let's just talk a little bit about sort of overall what happens for people in prognosis. So the long-term prognosis, people, 80% will have falls, 80% will have cognitive impairment, and 50% will have dysphagia. So when we're thinking about medications, it is not just medications to manage the neuropsychiatric symptoms that are so common. We have to think of all of these common geriatric syndromes. So what do people get? Parkinson's disease causes urinary retention and incontinence. It causes constipation. It causes dysphagia, so problem swallowing. So you have to think about what medications are you going to use or not use to manage those symptoms as the person's dementia progresses. So we want to use medications that target our symptoms. So remembering also that as people develop dementia, they have a much more frontal lobe kind of picture, which is executive function, impairments. So for the autonomic symptoms that people get with Parkinson's disease, that's going to be orthostatic hypotension. We will use something like midodrine or fludrocortisone because that often contributes to falls. So orthostatic hypotension is when you stand up, your blood pressure drops. And that is very profound. And the key is I almost invariably stop all antihypertensive medications in my patients because that dual medications, when we add other things, increases their risk for falling and increases their risk for postural hypotension. Other common symptoms are anxiety and depression. And again, when you have Parkinson's disease or Lewy body dementia, you have to consider how these medications are going to affect their Parkinson's disease and how they're going to affect their balance, their risk for falls, their incontinence. So we want to think about, typically we use medicines like SSRIs, like citalopram or Zoloft, or we may use something like nortriptyline. But as we start layering on all these medications, we have increased risk for having people have concomitant adverse side effects. So because people with Parkinson's disease with dementia tend to be frail, you always have to be cognizant of what you're adding. People often have something called freezing of gait, which we refer to as fog. Donepezil can be very helpful with that. That is one of the brain medications, the anticholinergic brain medications. It can also be very helpful with visual hallucinations. But as you can see, that also, it can increase your risk for fainting and it can increase urinary incontinence. So you can see how there is this issue that happens. The one thing that people always want to know about is, how do I treat the paranoia, the visual hallucinations, the agitation? In Parkinson's disease and Lewy body dementia, you cannot use the traditional antipsychotic medications because those in and of itself can cause Parkinson's disease. So we're very limited. So that's why you often see Seroquel. So what is Seroquel? It is an antipsychotic medication with weaker antipsychotic properties. So at the lower doses that we often use it, we get some antipsychotic property and a lot of sedation. So we often will use that because it's less likely, but still can cause increased Parkinsonism, the tremor, the rigidity, the difficulty walking. So it's really important to think about each medication that we give and how it targets the specific symptom. And as we're approaching medications, there's 4 principles that we have to use. That is that we want to know what is our goal of care, what is our treatment target, how long is it going to take the person to benefit from the treatment that we're giving them, and put this all under the umbrella of their life expectancy. If they're going to live for 3 weeks, it's a different thing than if they're going to live for 4 years, 5 years. So that I use that principle of appropriate prescribing with all of my patients. And And so it's not just applicable to people with Parkinson's disease, but also applicable to anybody that you're trying to understand what medication is being given. So the big no-nos in older people, but particularly in Parkinson's disease and Lewy body dementia, are anything that has anticholinergic properties, because that will worsen their Parkinson's disease and can cause a delirium. So what are those medications? That's going to be things like Benadryl. It'll be anything that we use that's prescription for stopping urinary incontinence. It will be things like anti-nausea medicines, not Zofran, but Composite. Reglan that we use for helping people if they have indigestion. And then the last thing that is the big no-no in Lewy body dementia is you absolutely cannot prescribe antipsychotic medicines like Risperdal and Zyprexa, because that can cause an extreme thing called neuroleptic malignant syndrome and just make them very, very ill. So I see my 2-minute warning. So I'll stop there. That was a lot of information condensed in a very short 10 minutes.
Thank you so much, Dr. Danica. That was really wonderful. And I would just want to remind everyone on the call, if you do have questions for any of our panelists, please pop them in the chat window over to the side. But we do have a question here for this shorter Q&A, Dr. Danica. How do you handle the patient who wants to frequently tinker with her own meds without consulting her doctor?
So that's a very general question. I think that is in the falls under the strategies we use to manage people with dementia, and it's all about partnering. So there isn't a simple answer. The answer is we have to partner. We have to partner with the physician. We have to partner with whoever's caring for them and get alongside the patient, because it's about a sense of having autonomy and self-efficacy. And so preserving their sense of self without infantilizing them and working in partnership. And one of the keys is to start paring down the medicines so you only give what is absolutely necessary. Mm-hmm. And so that makes it easier to then help manage things and get rid of things that might be damaging to them, like antihypertensives if they take 2 of them.
Great. Thank you so much. I'm going to turn it back to Paula to introduce our next presenter, but thank you, Dr. Danica. We'll have probably a few more questions at the end for you, I think.
Okay. Thank you, Dr. Danica, and thank you, Amanda. Our second speaker is Dr. Melinda Ginn. Dr. Ginn is a geropsychologist with a 40-year career specializing in geriatrics and the treatment of the psychosocial aspects of acute, chronic, and life-threatening medical illnesses. In addition to a 20-year career at Kaiser Permanente, she was chief psychologist at Mercy Retirement and Care Center in Oakland. She has worked in various geriatric medical and mental health settings, such as the Visiting Nurses Herrick Hospital Geriatric Partial Hospital Program, Alameda Hospital Geriatric Acute Psychiatry Inpatient Program, as well as in private practice. She is one of the founding instructors in the professional program in aging and mental health at UC Berkeley Extension, where she has been the lead instructor in aging for the past 15 years. Today, Dr. Ginn will present on the psychosocial aspects of Parkinson's disease with a focus on the patient and their family.
There we go.
Hi, everyone. Thank you so much for that great introduction, Paula. And thanks to Michelle for presenting already on so many important psychiatric issues in Parkinson's disease. And I want to start with some slides. So Amanda, I guess if you can put up my slides. This is from a survey done by the Parkinson's Disease in America group. They did it in 2018. And what they said was, well, we know a lot about Parkinson's from research and from practitioners and clinical trials and things like that, but let's hear from the Parkinson's patients themselves. So they interviewed over 1,100 people who were living with Parkinson's disease and 515 caregivers. And are you going to advance? Okay, so what they found is that, as it says there, Parkinson's goes beyond just having a tremor in terms of symptoms, that 71% reported fatigue. There was tremor, trouble sleeping, changes in writing, which we generally see as like micrographia, slowed movement, difficulty walking, impaired posture and balance. Go ahead, Amanda. And that cognitive issues were a real concern, and that there was difficulties reported in attention and concentration, in verbal fluency, information processing, memory, and executive functions. Probably mostly things around disinhibition and problem solving or reasoning. Go ahead, Amanda. Now, in terms of quality of life, 69% felt like they were losing hope with their condition. 51% reported a lack of energy. A third of them reported living with pain. And 20% said that they were having trouble meeting the needs of their family. And the last slide. So some of the things that people reported receiving help and support with were emotional support, finding coping strategies and stress management techniques, and help with household duties. So Amanda, you can stop the slides and we'll go back to, yeah, I don't know why I'm not showing up here on the gallery view, but yeah.
Yep.
Okay.
Yeah.
For the speaker view. Anyway, what I want to say is that one of the hallmarks of Parkinson's disease is that it really is an amalgam of both the physical and the psychological syndromes. And that, you know, as Michelle pointed out, there are a whole host really of psychiatric symptoms that occur in Parkinson's. And some of them, of course, involve things like over half the Parkinsonian patients report anxiety and depression. So we have some of the garden variety kinds of psychiatric syndromes, but even more so what we see are the hallucinations. And these are somewhat unique to Parkinson's because people will actually hallucinate fully formed humans. And the hallucinations are very egocentric. So they don't see that there's a problem with them. They really fully believe that those people are in their environment. And I've had patients report to me things like they won't sit down for dinner until there's a place setting for their friend. I've had people report to me that they believe that they have a sweetheart and that they have to go meet their sweetheart. And I first found out about these fully formed humans when I was working at the visiting nurses 25, 30 years ago. And I went in to see one of my patients, and I was going to sit down, and she said, "No, honey, don't sit there. That's where the little girl sits." And she believed that there was a little girl that played in her hallway and would come in and sit with her. So this issue of hallucinations is also fairly difficult, again, as Michelle was talking, that use of antipsychotic medications is very troubling. And in fact, the whole balance between effective medications for Parkinson's and their trying to control for hallucinations is very challenging and very difficult. And it's probably one of the hallmark issues, again, in Parkinson's disease. So the other thing about Parkinson's disease, it's very unique to most of the dementing disorders, is the effect on family. And what we see is a big ripple effect. So that Parkinson's is a challenge because it does get diagnosed later in life, usually starting in someone's 60s. And by then, they often have very long and enduring marriages and relationships. And there can be issues in that marriage. First of all, the non-Parkinsonian spouse is going to have the burden now of doing all the tasks that were probably shared somewhat. And also they have to make medical decisions. They are the guardian of the Parkinsonian patient for the most part. And that can be a tremendous burden and a tremendous stress. And the other thing is that what I have found in treating a lot of family members is that sometimes they can have survivor's guilt because they're not ill and they see their partner tremendously ill, because Parkinson's, as it goes through the phases and the course of the illness, can be extremely debilitating. And when you get something like a Lewy body dementia, which generally occurs early in the course of a Parkinson's diagnosis, it's also extremely devastating because you usually have a younger person, somebody in their 60s, who is fairly incapacitated, and it's a rapid disease. So Parkinson's you can live with for maybe 10 to 15 years before you even see an onset of like a Parkinsonian dementia. But Lewy body, you may have the diagnosis only for a year, and then you start having Lewy body symptoms. And Lewy body disease, sometimes the course of that illness is so rapid, it might only be like 3 years before somebody becomes so critically ill that they are, you know, placed on palliative care or hospice care. So it's really important to treat the entire unit. So you want to be treating not just the Parkinsonian patient, but the spouse, their children. It's really a family involved illness. And I think it's very important to partner with the Parkinsonian patient to define who really is in what we would call now their treatment bubble. I mean, who is important to them and who interfaces with them, and provide supports for that person. A lot of the time we want to engage the spouses and the family members in support groups, for different reasons. For Parkinsonian patients, it really can help stabilize them. It can normalize their experience to some extent. It can offer them hope and promise, and they share a lot of community resources as well. For the family members, it provides them with an important source of supports and ability to also get information, maybe to vent and to express their worries and their concerns, which of course they don't want to necessarily be sharing with their partner, with the Parkinsonian patient themselves. Let me see. I also want to talk just briefly about the treatment team, because I think this is really important. I did spend my whole career basically working in multidisciplinary treatment teams, where the colleagues that I worked with are the colleagues I'm going to advocate that you work with also. And that includes primary care physicians and the specialty physicians like the neurologists, also the rehab specialists, OT, PT, speech. Obviously, my team's always included me as a psychologist, and it's very important you work with a psychologist who is a specialist in the treatment of medical illnesses and preferably geriatrics, because they're going to really understand the scope of these illnesses and know the treatment options for the patients. Also, social workers are really important. They act as case managers. They also know all the community resources and how to connect your patients to them. And the treatment in illnesses like this is very broad. So you're going to see a lot of interventions from the community. You're going to use a lot of community resources, whether they're specific to Parkinson's disease, like the Parkinson's associations, or different sort of homegrown Parkinsonian support groups. We have those all over the Bay Area. And we also have things like Parkinson's dance groups and yoga groups specifically for these patients and their movement needs. And that's the other thing also, is that I know Michelle and I both take a very holistic approach. So we're not only using traditional Western interventions, but we're also looking at non-pharmacological interventions like diet, exercise, Tai Chi, acupuncture, massage, meditation, all of those things need to be brought into the picture. So I call the treatment of Parkinson's disease one in which we want to cast a very wide net, both in terms of who we're treating, how we're treating, who's on our treatment team, and also what interventions we want to use. So, yeah.
Thanks, Dr. Ginn. We do have one quick question for you at this time. Since Parkinson's dementia can present at an earlier age than other forms of dementia, what are some of the psychosocial issues that caregivers need to be aware of when looking at resources, caring for their own loved one, given their youth with this form of dementia?
Yeah, I do deal with this a lot because so many of our resources for, say, the dementing syndromes are geared for older adults. And we're maybe with the baby boomers coming on the scene, we're going to see interventions for younger people. And by younger, we're talking about people in their 60s as opposed to people in their 80s and their 90s. And so I think that what I would probably do is focus a little more on the community resources, specifically for Parkinsonian patients, because there you're going to find a population of younger people. Mm-hmm. Often it's just not a very good match especially when you're looking at placement, which does frequently happen, especially, with Parkinson's, because quite often it's kind of a hardship on the family to have to deal with hallucinations that cause impulsive behaviors in the Parkinsonian patient. And so those families are sometimes needing to look for a placement, and oftentimes the patient gets placed in a dementia unit where in fact they're surrounded by older adults, and they recognize that. They recognize the difference, and sometimes it's not that good of a fit. So you might be looking for facilities where they have some younger residents as well.
Great, thank you so much. I'm going to turn it back over to Paula to introduce our next presenter.
Thank you.
Thank you, Dr. Ginn, and thank you, Amanda. Our third speaker today is Dr. Lisa Mccarthy, who's a clinical researcher and author, as a physical therapy doctor and board-certified clinical specialist in geriatric physical therapy. Dr. McCarthy is also a licensed professional fiduciary, volunteer assistant clinical professor at UCSF in the Department of Physical Therapy and Rehabilitation Science, editorial board member of Geri Notes, board member of the Dementia Action Alliance, and president of the San Francisco chapter of the Professional Fiduciary Association of California. Today, Dr. McCarthy will share information about a Medicare-covered equipment option that can help people impacted with Parkinson's disease preserve their walking ability, so the need for using a wheelchair can be postponed for a few years.
Hi, thank you very much, Paula. Hi, everyone. My name is Lisa McCarthy. My first name is spelled L-I-S-E, but it's pronounced Lisa. It usually trips people up a little bit, so I just wanted to clarify that. You've heard from the other two speakers about medications and fall risk and frailty and pain and balance problems and so forth. And it's something that I work with folks who are impacted by Parkinson's or any other kind of neurological problem, that I work through those problems and find solutions for them. And the piece of equipment that I want to talk to you about today is trying to, it actually started out trying to figure out what we could do to help folks who are sort of in that gap of having physical therapy, being active, having the right supports in place, having the right medications in place, addressing the deconditioning that can happen when illness comes, and going through rehab and getting them back up to where they need to be so that deconditioning is not really impacting their movement. So they've done everything right and they have a good team in place, but there's still this problem that they've been having with moving from one place to another. And when the body doesn't move, it sets things up for all sorts of difficulties. It makes people weaker over time. It can cause pain because people are stiff and not moving. It can increase fall risk. So it's almost like, we're dealing with a sort of a vicious cycle in a way, by not having this this extra bridge. And a lot of people that I have been working with over the last 20 years were going into wheelchairs a lot sooner than they really needed to do. And so I worked with a company called Ustep Mobility. They're based in Minnesota. And I explained my situation and the patients that I was working with, because they have created a walker that's specifically designed for people who do have Parkinson's disease. And what's wonderful about this walker and why it's covered by Medicare is because it has some interesting features. One of the features is the braking system. So the braking system is what they call a dead man's grasp. It comes from train technology, so that when trains are being operated, there's somebody who's holding on to a device, and that device has to have some kind of human contact on it, because if that person faints, for instance, the conductor faints and lets go, then a series of braking systems in the train will slow the train down and stop it, so that the train doesn't run away on the tracks when the conductor, something happens to the conductor. So it's a safety feature. So they took that technology and they incorporated that braking system into this walker. So for people who have a walking issue where, you know, the walker is getting away from them and the walker is getting further and further away, we don't want them to fall on their face, right? We want them to be able to stop the walker. And how they do that is they just let go of the brakes. You can't move the walker really easily unless the brakes are initially engaged. So in order to stop the walker, you actually let go. So it also helps with memory issues. So for people who want to turn around and sit on the seat on this walker, you know, they're going to let go to turn around to sit. And one of the things that we don't want them to do is to be on a walker where the walker is going to fall away from them as they're turning around to sit down, and then they sit down on the ground and break their pelvis. Yeah. So this kind of a walker is really, really a wonderful walker for that braking system reason. But the other part of this walker that is really cool is it uses two other mechanisms that bypass in the brain the parts that are impacted by the Parkinson's disease. So it uses visual and it uses auditory cueing to help people get a sense for the rhythm of movement and the space for movement. So one of the things that happens with Parkinson's is your world sort of gets smaller and smaller and the brain forgets. That's why exercise that incorporates big movements helps maintain those big movements over time. Well, the same thing happens with stepping. Steps get smaller and smaller and smaller until you have this kind of a shuffling gait. But with this walker, there's a laser light that is put on the ground. And so you visually get a visual cue as to where you step. So as a physical therapist, one of the things that I do when people get this walker is I get them on a walking program, because usually their walking system in their brain, how their brain is managing their legs and the stepping, it's a little rusty because it hasn't been taking big steps before. So we set them up with a walking program that has them practice taking these bigger steps over and over again for a few minutes, because I mean, exercise can be tedious and boring, but just that little bit helps with the motor memory of walking, so that when they get up, if they're, you know, people get up and they forget to use their walker, which is really common for a lot of folks with or without Parkinson's, their body has that motor memory to take a bigger step if they lose their balance. The other thing with this cueing system is that it has an auditory part to it. So you can actually set, when you're doing walking exercise, you can set a rhythm to the walking. And so one of the things that I do as a physical therapist is we might start out with a slow auditory beat, right? People are taking one step then the other because they have to really think about what they're doing. How far do they have to go? But once they've mastered that, and just about everybody can, then we speed up the auditory cueing so that coordination of the muscle system, the neuromuscular system, gets to have the practice and regain that faster movement speed. And so then we develop a walking program where people are walking faster. Now, if you're walking faster, your balance reactions are going to be more brisk. So again, that reduces fall risk. So this walker is a wonderful walker for those three reasons. And the lovely thing is that it is covered in large part by your Medicare benefit program if you have traditional Medicare. The company has really great customer service. And I just want to say, I don't have any financial relationship with this company. I never have. They have given me 3 walkers in 20 years for me to try out and use with my patients. They do that for all sorts of rehab providers and hospital systems all over the country. But I have not received any financial money for working with them or talking about them. I know Parkinson's because it hasn't impacted my family. I know it because I have a grandparent who had it. And that's why I spent so much time working with them, trying to figure out how to get a piece of equipment in place to bridge this gap. So this walker has been around for a long time, but the thing that has been missing up until just a few years ago when I reached out to them and worked with them to create this extra feature is putting platforms on top of the walker. You might have seen, the traditional walkers that have 4 wheels, and you have to kind of use them straight armed in a sense. So that works for a long time for a lot of people because they have the strength in their arms. But as this disease specifically gets advances, what happens is the arms can't really take over for the legs. For a while, the arms and legs can help with walking, right, and help stabilize the balance. But it does get to a point where your upper body just can't maintain and take over for what's not working in the leg. But if you put platforms on the walker, then the arms don't have to work so hard. And so then the energy that you have can be fed back into the legs, and the legs can still walk. And so the walker that I want to show you, the video that I want to show you today is the traditional Ustep walker with the laser light. You can see a woman walking with it. But I also want to show you a picture of the walker with platforms. And so you can visually get an idea about what that's like. And it's covered with a prescription from your physician or nurse practitioner or physician assistant. The company will walk you through the process that's needed to get it covered. Some elements are not. You have to pay out of pocket for the visual module and the auditory module and the platforms, but the basic walker is covered, and I think it's somewhere between a $500 and $700 benefit. So it's really worthwhile to look into this. So if Amanda, if you will bring up the video and then the picture, people can see what I'm talking about. So so this is a gentleman here in San Francisco. He got the first walker in California a few years back. And I don't know if you can see where his feet are. It's a little bright. But there's a laser light, sort of a red-orange line that is down by his feet. And so he can look and make proper steps when he's walking this walker. You can see the grip where he's holding on. You can see that he's squeezing the brakes. So again, he's getting ready to move the walker forward. You can see that there's a seat for him to sit, but there's a bar in front. So when you graduate to that system where you need more support, upper body support, you can't sit down on the walker anymore. The walker is very, very stable. It's hard to tip over. I mean, you can tip it over if you really work at it. It does come in 3 different sizes. It comes for people who are very petite, people who are of average height, and for people who are over 6 feet. So you want to really work with them to find out, what might be right for your loved one or for you. But that's what I wanted to present today.
Okay, thank you so much. Let's see, I think we had a question here. Can you speak to the requirements for the Ustep walker equipment to be covered that someone might have to meet in terms of eligibility?
Yeah, so it's really straightforward. Mm-hmm. You have to have a prescription from a diagnostician. So a diagnostician is an MD, an MP, or a PA. I'm a PT, and although in some states physical therapists are allowed to diagnose, in California we're not. But if you have a prescription from one of those traditional diagnosticians, then it will say on there what the diagnosis is. And the diagnosis should say Parkinson's disease. And the treatment is a Ustep walker, which is the traditional one, or a Ustep walker with platforms, or a Ustep walker with the cueing module, And then that company has what they need to fulfill the order. There's some additional paperwork, but they'll walk you through that. And it's just a matter of making sure that people who have a balance problem when they're walking, which is basically ataxia, an uncoordinated way of walking, which affects people with Parkinson's, but it also affects people with stroke and multiple sclerosis. And this walker is good for people who are dealing with those diseases too. It's not just for folks with Parkinson's.
Great, thank you so much.
Yeah, you're welcome.
So I'll turn it back to Paula to introduce our final speaker for today.
And I think we can probably, Dr. McCarthy, include that in the resource material that we'll send out after the salon as well. So thank you very much, Amanda and Dr. McCarthy. Our final presenter today is Jim Kimsey, founder and CEO of Tender Rose Dementia Care Specialists, the nation's only health services company exclusively dedicated to one-on-one dementia care. Before starting Tender Rose, Jim had more than 20 years of healthcare experience educating physicians, nurses, and other caregivers on how to use new technologies for diagnosis and treatment of disease and to enhance patient safety. Jim holds a bachelor's degree in economics and an MBA from Stanford University. Today, Jim Kimsey will provide an overview of the challenges related to providing one-on-one care for clients with Parkinson's disease dementia.
Right. Thank you, Paul and Amanda, for organizing this. And I also just want to thank Dr. Ginn, Dr. Danica, and Dr. McCarthy for participating. And I want to tell everybody, like, one of the ways we decide what kind of salons to put on is what do we want to learn more about? And we just learned a ton today, and I hope you did too. I so much appreciate the expertise of these other speakers. What I wanted to do is bring in a little bit different angle, and it really is like, how do you take care of somebody who has Parkinson's dementia, and what are some of the strategies that we've used that have been successful for us? And I want to do that in the context of a case study of a client that we are actually working with, we've been working with for about 3 years. Her name is Lydia. She's in her early to mid 60s. She's a high-powered attorney. She had home care in the past from a traditional home care agency. And the interesting thing is Lydia really liked her caregivers. She was quite happy with their care, but her sister was not. And the thing that we noticed as we started to get involved in this case is that the caregivers would listen to Lydia, and Lydia basically depended on her caregivers for her physical needs, and that's what she looked to them for, and they could do a pretty decent job of that. But when she started to develop the dementia and started making poor choices for herself, they didn't really have kind of the dementia care skills to help her make good decisions. And so when we came on the scene, if Lydia didn't want to take her medications, that was no problem. If Lydia wasn't hungry, that was no problem. If she wanted ice cream for dinner, no problem. If she wanted to stay up all night, that was no problem. And what we saw is that the poor nutrition, the lack of exercise, but probably most importantly, the lack of sleep was really contributing to her cognitive issues. And doing things like giving her delusions and causing her to hallucinate and creating pretty challenging caregiving situations in the middle of the night, like going out into the street, the police having to be called, the family being called at all hours of the night. And so the thing that we did with Lydia, and we do with all of our dementia clients, is we really focus on it's what we consider the gold standard of dementia care, is really focusing on person-centered, activity-based care. And one thing is just understanding who Lydia is and what's always brought her joy and meaning, and then engaging her in those activities that always brought her joy and meaning at whatever level she can participate. And that's kind of the approach for all dementia patients. One of the things that's different with Parkinson's dementia that's actually quite helpful in getting them to accept care is a lot of times people with dementia don't have any insight into their cognitive difficulties. And that was true with Lydia. But one of the things that we've learned is almost anybody who has dementia, who has a physical difficulty or medical difficulty, will be more open to accepting care in those areas. And so the fact that Lydia had Parkinson's and knew she had Parkinson's meant that she was much more accepting of the care. And so to have somebody in her home and caring for her was not a problem. And then that gave us the opening to be a little more subtle about how we dealt with her cognitive challenges. One of the things that we identified is or there's actually, as we looked at it, there were a lot of things going on, but we realized there were three major factors that we needed to focus on to get her quality of life under control and to kind of actually reduce the behavioral challenges surrounding her dementia. And one was just getting her diet under control. In one of the important things with any dementia is letting the person with dementia make choices and be as independent as possible. But that, there's a big difference between saying, "What do you want for dinner?" and "I want ice cream," and approaching her and saying, "Hey, would you like, vegetable soup or chicken for dinner?" and letting her choose that. So what we were able to do is kind of set her up to make good choices around diet. We also really got her more engaged in exercise. She had a personal trainer. The personal trainer ended up helping her work with a ski machine, and that was something that was interesting to her, and she could still do, and it also helped with her balance. We have seen other Parkinson's patients. There are, pre-COVID, some great programs out there that are designed specifically for Parkinson's patients around boxing, and that can be a lot of fun for them and really help them physically. But one of the most important things was really getting the medications under control. And Dr. Danica talked about partnering with the patient, and Lydia really is involved in her medication decisions and likes to know what's going on with the medications, and sometimes, and still to this day, wants to make changes to her medications that aren't really good decisions. And so, around diet and around medications, we always listen to Lydia and we let her say what she wants to do and why she wants to do it. But part of the care that we have with all of our patients, but it comes in, it's probably even more important with Parkinson's dementia and Lewy body dementia, is we have the role of a care coordinator who coaches and supports the caregivers in the home, but also develops a relationship with the client and the family. And it turns out that that person's been across all of our Lewy body and Parkinson's dementia patients. It's really important to have this kind of trusted authority that they enjoy seeing, who can do things like talk them out of bad decisions around medications or diet. And usually it just involves listening to them, hearing what they're saying, and then suggesting, like, hey, maybe a lot of times it's just like, why don't we call Dr. Danica to see what she thinks? And then the patient will say, yeah, maybe I'll just go ahead and do this. They feel like they've been heard, and that they realize that it actually is a good decision to go ahead and take the medication as it was prescribed. So the thing with Lydia is by focusing on diet, exercise, and medication, then that helped contribute to a better night's sleep. And now she's been having a really high quality of life ever since we've been able to get those things under control. And every once in a while, we'll have some things like what I call either delusions around, maybe Lydia wakes up in the middle of the night. We see this with some of our Lewy body patients where they may have this trusted caregiver that they've had for a long time, but then they get some sort of delusion about who this caregiver is or what that caregiver is doing in their home. That creates a pretty big challenge, and that's where that partnership with the care coordinator also comes into play, because it's pretty hard to replace a caregiver at 3 a.m. When somebody needs 24/7 care. So to have the ability for a care coordinator to get on the phone and say, would it be all right if Susie just stays there for the rest of the night and it goes into the living room, but just we're trying to get Lydia to go back to sleep, and then we'll find you another caregiver tomorrow. And then usually by tomorrow they're in a better place, and we can basically kind of save that relationship with the caregiver. Sometimes we can't, though. Sometimes they get this delusion and it won't go away, and then we actually have to replace that caregiver, which is a shame because usually they've had a good long relationship. But we have to kind of work with the person and where their head is at, and let them maintain their independence as much as possible. So the three things that worked for Lydia were focusing on her diet, exercise, and medication, and making all that kind of led to getting better night's sleep. And she's continues to live a high quality of life. The family's very happy with not getting called in the middle of the night and not having to run out into the street and that type of thing.
Great, thank you, Jim. We do have one quick question before we open up the fuller panel Q&A, and that is around exercise. So since exercise plays a vital role in caring for individuals with Parkinson's dementia, can the caregivers at Tender Rose facilitate exercise programs in the home?
We do that a lot, and a lot of times we're partnering with the physical therapist to do physical therapy exercises that the physical therapist has prescribed. a lot of our clients will take on walks, and definitely it helps to have walkers and things like that. One of the things we always have to be really careful of is when they start to have that blood pressure drop, where they're an increased fall risk, and little things like making sure when they sit up in bed that they sit there for a minute or so before they stand up to try to get acclimated to, they don't just like pop right up. But we definitely do a lot of, I mean, for all of our patients, and certainly our Parkinson's and Lewy body patients, exercise is a big part of what keeps them happy and sleeping well at night.
Great, thank you. So we have a couple of questions and just a few minutes left today. So I wanted to address a question that came up around hallucinations. So someone asked, why attempt to medicate hallucinations if they're not troubling to the patient? So I don't know if that's something Dr. Danek or Dr. Ginn, whomever wants to hop in on that. This is when it's not distressing, these hallucinations.
Okay.
That's a great. Oops.
You want to go ahead, Michelle?
Sure.
Oops, hang on one second. Looks like you got muted back on. Okay. Oops, can you unmute yourself? I don't.
There you go.
Okay.
Can you hear me?
We can
Yes.
Okay. It's a great question because it goes to the principle in which I use in all of my medications, which we only medicate for neuropsychiatric symptoms that are distressing. So the hallucinations are often distressing to the family, but if they're not distressing to the individual, we don't medicate for them. Because remember, there's no free lunch in medicine, and every medication has a side effect. So it's really about trying to understand how this person, what the impact is for this person. So I just had somebody who is hallucinating all the time at night, and the family and I had this exact discussion as we sifted through his multitude of issues in his Lewy body dementia, and came up with, what are the primary issues? The primary issues are his anxiety, his restlessness, and his hallucinations are further down the list. And at this time, even though they wake him up, we can live with it.
Okay, great. Thank you.
I do have one thing to add to that. I completely agree that as long as the hallucinations are not disturbing to the patient, they can, not be necessarily medicated. But I do want to say that it's always a fluid situation, and that sometimes somebody can be perfectly agreeable to some of their hallucinations, but then there can be times when, in fact, their behavior becomes a little bit dangerous because maybe they're, like I said earlier, I had a patient who thought her sweetheart was coming for her, and she believed that the sweetheart would drive down the driveway and honk for her to come out, and the only problem was she lived on the second floor. So as long as safety measures were put into place, that was okay, and she didn't need to be medicated. But there are a lot of different ways in which the hallucinations can affect the person, even if they are not frightened by them. So I just think that that's important to include.
Great. Thank you. It looks like we might have time for one more. Lisa, I just posted the info you shared about the Ustep walker, and we will be sharing a link to that article that you referenced in our follow-up email to the group tomorrow. But someone had asked a question about, are you able to try the Ustep walker equipment out before purchasing it?
Not during the pandemic.
Fair enough.
Yeah, my physical therapy house calls practice is shut down right now. We'll see how that goes. But, there are clinics that have these walkers, as well as other sophisticated walkers. There's a lot of walkers out there to address a lot of people's different needs. And so the best option that you have is to contact, your hospital or outpatient physical therapy clinic. And see if they have these walkers, because it really is, it's helpful because there's different types of platform walkers and there's different types of walkers out there. And to have somebody who understands what a person is needing as far as their difficulty with a movement or walking, to have that input, you can make sure that since you are paying out of pocket, or Medicare is paying out of pocket for the walker, you get the right walker for what your needs are. That Ustep walker is not for everybody. There are other types of walkers, and there's other platform walkers that are more appropriate for different kinds of needs. I mean, as we age, we are dealing with a lot of different kinds of things. So sometimes, people not just have Parkinson's, but maybe they have hip pain, or maybe they have a shoulder problem. So they really can't operate the Ustep walker because of how it's designed and the stress that it puts on the shoulder. Different type of walker has to be identified that is easier for them to maneuver. So those are the kinds of things that the physical therapist can help people with. But yeah, it's a good idea to try it out first. You don't want to just buy it.
Mm-hmm. Okay, great. Thank you so much. And thank you to everyone. And those were some great questions from the audience. So I'll turn it back over to Paula to wrap up here.
So thank you, Amanda, Jim, and all our panelists. This concludes our salon on Parkinson's disease dementia. Thank you so much for attending. We will be sending you a follow-up email with additional resources on Parkinson's disease dementia, a link to the recording of the salon, and a brief survey for feedback and participation in future salon events. And on that note, our late October salon will be addressing providing successful dementia care to couples when one partner is cognitively intact and the other is on the journey. Thank you very, very much, everyone. Stay safe, be safe, and I hope that you learned a lot from our salon today.